sudden onset. You've been okay, you feel weak, you're shaking, confused. When that progresses for the next 5 minutes, you can actually drop down.
And die.
Yes, that's the right word I was looking for. We used to say that, that one has a big stomach, is rich. No, actually, the more you have a big stomach, the worse for you. I'll emphasize, diabetes and hypertension do not cure. I've had patients who come to me and they have taken urine, their own urine. By the time you're diagnosed with diabetes, it means you've had it for the last 7 years. In the men, this is a cut for the men. When you notice that issues are not going on well at home, it may be an indicator that you're actually already diabetic, because diabetic is the leading cause of erectile dysfunction.
What would you say are your top 3 pieces of advice that you can give someone today to help them avoid developing diabetes or hypertension?
We recommend that these 2 hands should be a portion of green vegetables. Protein should be the size of your palm. The portion, the carbohydrates, the portion of the carbohydrates should be the size of your fists. For the raw salt, that you have to take it out of your menu.
You cannot add.
Never add raw salt, because it will harden your blood vessels and worsen your hypertension. You've had people come into hospital, they are diabetic. A few years down the road, you hear their legs have been cut off. So usually the reason why their legs are having issues is because insulin is like an Uber. It is an Uber taxi. So the Uber taxi comes and says, hey, where are you going, glucose? I'm going to one area, which is the muscle. Hey, what are you going to do there? I'm going to give them some energy. Okay, let's go. So the Uber guy, which is insulin, drives the glucose. Now, because there is a barrier, there's a roadblock at one gear, it means that the glucose is going to reach there together with the Uber guy, and then you're not going to have this glucose reaching the target organ, which is the muscles. So the muscles are going to be deficient of this energy. Weakness is going to set in. And then the muscles are going to...
Welcome to CEO Insights. On here, we talk to CEOs, corporate leaders, and other key people of influence. If you'd like to be on the show or know someone who should, please get in touch with us. If you haven't yet subscribed, please consider doing so right now. When you subscribe, you enable us to continue growing, which in turn enables us to continue attracting and bringing you these intriguing guests. Please remember to leave a comment in the section below and tell us about your experience watching the show. Thank you, and let's get on with this episode. Thank you for coming on the show. We're very glad to have you here.
Yes, thank you so much for having me on the show today.
In layman terms, please define for us what diabetes is, what hypertension is, and what high blood pressure is.
Diabetes is a condition whereby we're having a lot of blood sugar circulating inside your blood. So ideally, blood sugar is one of the vehicles that help us do whatever we do, because as they say, that our bodies are made out of blood and water. So blood has sugar, has oxygen, and other nutrients. So it is the glucose that helps us with energizing the body. The glucose gives us energy to do whatever we do. So the problem that usually happens when someone is diabetic is that, yes, the sugar is actually there. It is a lot in your saturation, but it is not reaching the target organs. It is not reaching your muscles. It is not reaching your brain. It's reaching the brain because there is a direct flow, but it's not reaching your muscles to give you energy. So what usually happens is that we are having a lot of fat, especially people who are obese, that is impairing or that affects the movement of this sugar from your blood into your muscles to give you energy to do your work that you do. So what really happens is that because of this layer of fat that is lining your muscles, it's acting as a barrier and it is affecting the movement of this glucose. So the pancreas's role is to produce insulin. So the insulin that is being produced by the pancreas, particularly the pancreatic beta cells, there are those small cells inside the pancreas that produce this insulin. Insulin is like an Uber. It is an Uber taxi. So the Uber taxi comes and says, hey, where are you going, glucose? I'm going to one area, which is the muscle. Hey, what are you going to do there? I'm going to give them some energy. Okay, let's go. So the Uber guy, which is insulin, drives the glucose, and then they go into the muscles, and then he drops him off, and then he does his thing. Now, because there is a barrier, there's a roadblock at one gear, it means that the glucose is going to reach there together with the Uber guy, and then you're not going to have this glucose reaching the target organ, which is the muscles. So the muscles are going to be deficient of this energy. Weakness is going to set in. And then the muscles are going to tell the pancreas that, you guy, we already told you to give us energy. We are waiting for glucose, is not coming. What's the problem? Is there a problem with the Uber? You don't have tires? What is the problem? So what really happens is, now the pancreas is put to task to produce more insulin. So in the long run, we are going to have what we call hyperinsulinemia. The pancreas is going to produce extremely a lot of insulin to see that this insulin drives this glucose into the muscles to give them energy. But remember, there's a roadblock, there's a barrier. So along the way, the pancreas is going to undergo burnout. So you guys have really tasked me and I'm tired. Leave me alone. Give me a break. See? And then at the end of that day, we're having a lot of glucose. We're having a lot of insulin. But then the target organ, which is the muscles, are not getting the required element, which is the glucose. So when you check, you notice that there's too much sugar. Ideally, someone would think that if someone has a lot of sugar, they should actually be the strongest people on earth because there's a lot of sugar. But actually, the reverse is true, following the science that you have talked about. So what will happen is that there is a lot of glucose in the blood, which later becomes actually toxic. Because the more it keeps in the blood, we're having it transforming into other components that are going to cause damage to the organs, as we are going to see later on. Now, what will happen in diabetes, as we have explained. Now, the other thing is that because of the increased pancreatic cell, because of the increased burnout at the pancreas, we are going to see the pancreas now giving up on producing insulin. Along the way, the insulin levels are going to drop in the blood. And then remember, the glucose is also a lot in the blood. It's giving you all these other symptoms, the kusanyalala and those other things. So, and the muscles are not getting the energy that they need. So at the end of that day, someone is going to become very weak, and the weakness is coming because there is no glucose to give you energy. See, someone is going to drink a lot of water. Why? Because there is too much sugar in your blood. Sugar is very, very concentrated, and it's going to switch on your thirst centers, and the blood is going to say, you guys, this is too much. The sugar is too much. The concentration of blood is a lot. Give me something to dilute this sugar.
That's where the thirst comes in.
And then the thirst, very good. Now the thirst sets in. When the thirst sets in, you're going to drink a lot to kind of dilute this too much blood sugar. And what is going to happen when you drink a lot? The water has to pass out as you drink it. You're going to find yourself urinating a lot because you're taking in too much of the water. See? Now, where does the increased hunger come in? Because you already have too much sugar, then where would the hunger come in? Remember, in one day here, there is no glucose. And the muscles are telling the pancreas is not doing its role. The muscles are assuming that the pancreas is not doing its role. Now, the body is going to say, okay, I'm fed up with you. Let me go to the higher centers. They want to switch on the higher centers, go to the higher centers, switch on the hunger centers, and then the muscles are going to instruct the brain, for us to give us food, we are not getting glucose. We have talked, this guy is not helping us, so give us food. And then you're going to look for nyamachoma, look for everything. You eat everything that is around you. That's where the increased eating, or what we call the polyphagia, comes in. Because, yes, you have too much sugar, but it is not reaching its target organ. So if it's not reaching its target organ, we are going to see it's going to be like a negative feedback to the pancreas and to the higher centers in the brain, which are going to give you all these symptoms that are classical in diabetes. Now, where does the weight loss come from?
You're eating too much.
You're eating too much. The sugar is a lot. Why are you losing weight? Because ideally, I would expect you not to lose weight. Now, I'm taking you slowly. Remember, the muscles have told the pancreas to do its work. And they assume this guy is not listening. He has given you a deaf ear now.
And the pancreas
is out. The I'm already out. Now, the muscles are also instructing the brain to tell the mouth to eat. And it's doing its work. You're eating everything that is passing by. And they are still not getting what? Energy. The body is going to resort to a catabolic state or a breakdown state. What that means is the body is going to say, okay, now let us burn this muscle. Let's burn ourselves as muscles, produce energy. Let's change this fat to give us energy. Because these guys are not caring about us. And then the body is going to go into catabolic state.
So the weight loss is like a self-preservation kind of thing.
Exactly.
What is it called? Okay, there are some animals which actually eat their young to survive
Yes.
in extreme cases.
It is a survival mode, as you said. The body it has tried everything and it looks like things are not working out. So it goes into a survival mode. It burns muscle to produce protein. It burns fat to produce energy, keto acid, which is, of course, it's a bad thing, but that's what it has to give it some form of energy. Yes.
So this weight loss is a rapid state weight loss. It happens over a short period of time. From a person who has been, for example, big and they are experiencing sudden weight loss, this is a symptom. But the fact that it is sudden like this, does it mean that the body is in a, like emergency state, or it is critical, it is about to die? Or
no, it's not about to die, but it's an emergency state. It's a survival mode. It's an emergency state. Because all the other options have run out, and I'm left with this one to help myself. So it undergoes this kind of emergency catabolic or breakdown state for survival. Because ideally, when the body burns out the fat, it produces the other end products, keto acids, acetoacetate, and the others, which will actually give it some form of energy.
but
not as glucose, but in the long run, these keto acids that are being produced as byproducts are actually toxic, and they are going to cause serious consequences on the body, which can actually throw someone into what we call a diabetic emergency called diabetic ketoacidosis, or even a diabetic coma. Yes.
I've seen a situation whereby a person was tested, had diabetes, and had high insulin levels, which is what you're explaining. The pancreas created it. It could not get to the muscle because there was a roadblock of fat. So the muscle requested more, the pancreas created more. And here there was a reservoir of insulin, right? When this person went to the doctor, during that visit, the thing that the doctor did is prescribed even more insulin. Now, why would the doctor prescribe more insulin when the person already has a reservoir of insulin in the body?
When you look at it, ideologically, you would think that there is a lot of insulin, ideologically. But remember, insulin has a half-life. And usually the half-life is a short half-life. So the pancreas produces, and initially you have a surge, but along the way, it works, it's in saturation, but then the half-life, So along the way, they get insulin depleted. Along the way, as you have explained. Now, to answer the question, why would we give insulin to help in these patients? So what usually happens is that what insulin does, the exogenous insulin that we give through the injection, is that for it has the ability to penetrate these barriers, unlike the endogenous insulin. So for it will be able to overcome the barriers, and it is able to deliver this glucose to the end organs.
So that means it would be like a temporary measure to open the barricade.
Yes.
For the normal glucose to go through, for the normal, okay. Would that then trigger the pancreas to start producing normally, or, okay.
Okay, now, when that happens, you've given your exogenous insulin from our injections, and then, the glucose now starts moving, doing its thing, goes into the muscles, provides energy, you're being weak, the weakness goes away, and all those things you literally come back to life because of the insulin that is being given. Now, when the pancreas notices that, I have a helper who has come, remember, it had undergone almost pancreatic beta cell burnout. it is fatigued. It has been working night, day shifts. So it is fatigued. So when it gets someone to come and cover up, it is going to go and rest. Like literally, I can say in layman's language, it will take leave. So when it takes leave, because there is someone helping it, everything is going to go back to normal, ideologically. So the pancreatic beta cells will come back, they will start to regrow back, the reserve is going to be replenished, the healing is going to take place inside the pancreas, and then along the way, it will wake up, and then it will start working along the way. That is why we actually advise our clients that when you come to hospital and we do these other parameters, we check the different tests, and we see that you actually qualify to start on insulin. Don't be rigid. Don't be rigid, because when you're rigid, it means that, remember, the pancreas is already undergoing burnout. And most of these drugs work on a fairly functional pancreas with some bit of reserve pancreatic beta cell. The guy is already burnt out. You're loading him with more drugs. What is going to happen is that along the way, he's going to lose all the beta cell functionality. And in the long run, you're going to lose out because you will not be able to replenish more beta cells. So it means that along the way, you're going to transform from type 2 to type 1. Because you're going to have very few pancreatic beta cells that are still doing their thing. However, if someone really qualifies to start on insulin, and we start them on insulin, we rest the pancreas, it heals. About 2 to 3 months down the road, we do these other parameters and notice, okay, sugars have dropped, your HbA1c, everything is now fairly good. Now we know that, okay, now the pancreas can actually do its work. So we can actually employ the oral medication. And then they work for you very well. The thing that I would also want to say, of course, for patients who have had diabetes, I would say that by the time you're diagnosed with diabetes, it means you've had it for the last 7 years. But I know
it's not yesterday.
It's not yesterday.
Not the food you ate at Christmas.
It is not that they've got to diagnose you, that the diabetes came that day they died. No. It means you've had it for at least 7 years.
Wow.
It means you've had it. So it means that the pancreas has been bearing with this for almost 7 years. And,
So it is, I'm sorry for cutting you short. So it is possible that you go for a checkup, they see that you have diabetes, and at the same time that they see that you have diabetes, also your pancreas is already spoiled at that time. It is possible. Since you have had it for 7 years or so.
There's a possibility. However...
And even your liver.
Yes. However, it still depends because there are different parameters that we look at. We look at it's a bit technical, but the HbA1c, it really guides us. And say, okay, how have we been doing? Maybe there is some bit of... And we also do other tests like the C-peptide and the others. So some of those tests that we do when you come to the clinic, they guide us. They help us know, okay, do we have some bit of beta cell reserve? Yes. Do we have no beta cell reserve at all? The moment you do that and you see that for example, your C-peptide is very low, then there is no role of tablets at all. So yeah, that's the person who has to be on insulin. However, if someone has been having stress to the pancreas and they come in, their sugars are high, all 20 millimoles, 15 millimoles, and their HbA1c is above 9, we usually recommend that they get on insulin, that we can have some bit of rest to the pancreas. And then, but there are also those patients who come to us and they will diagnose them with diabetes and do these other parameters, and we notice that actually not a lot of insult has been done. Yeah, there are still many that they come and there's still functionality, and then we give them their tablets and they do very well on their tablets. So not everybody who comes and they are diagnosed with diabetes on day 1 have to start on insulin. There are parameters that we look at. Those who qualify to start, those whom we actually start on one drug for the oral drug, those who need combination therapy, and things like that. The other thing that I would also want to talk about is usually as we manage diabetes, we always recommend that drugs don't come number 1. As clinicians, as physicians, we all implore that come and we first check your hypertension. We check your cholesterol. And then the diabetes comes third. Yes. When you sort your hypertension, you sort your cholesterol, you do your exercise. Usually the diabetes, usually down, unless someone has very high blood sugars and their A1C is up in the roof. See? But usually that is the chronology order that we usually follow. Manage hypertension, manage cholesterol, which usually most people forget. They manage hypertension and diabetes, and they forget cholesterol, which cholesterol can be an orchestrator of all the other complications, as we are going to see later. Yes.
Let's talk about that cholesterol. What is cholesterol? And that's the one that is leading directly to the high blood pressure. What is that?
Cholesterol is a pile-up of bad fat. It's like a pile-up of bad fat. So it doesn't happen in a day.
Also 7 years or so?
It happens, it is something that is accumulative. So someone has been having a sedentary lifestyle, we eat what we want, we don't do exercise, and then along the way the bad fat collects along the blood vessels. So the blood vessels that have, the bores that have been opened very well, or the lumen that have been opened very well, along the way, they become narrower and narrower and narrower.
Sorry. The fat, say we have a pipe.
Yes.
Is the fat building on the outside, squeezing it, or is it building on the inside, contracting the space?
The fat is actually within
the blood vessel.
Within the blood vessel, inside. So it is causing a lot of impaired flow. So the lumen that has been open, maybe, say for example, maybe 2 millimeters, is going to be maybe 0.5 along the way. So you notice that the flow of blood is going to be limited to the end organ, and the resistance is going to be high at the target, at the periphery, or at the end. So meaning the stress to the heart is going to be a lot. So the heart has to work a lot to push blood through these narrowed blood vessels, so giving you the hypertension.
There is a doctor who told me one thing one time. He said, if you have a pipe, a pipe of water, you know, if you just hold it normally like this, the water just comes down here normally. When you squeeze it, it shoots out. And he said this is similar to the same thing. When the cholesterol is inside the blood vessel and has reduced the space, the blood is sprouting out, and now what you're describing, the heart has to push with a lot of pressure. To push this blood to go through, leading to the high blood pressure.
Yes. And actually that phenomenon that we've just talked about can actually lead to the complications like a stroke. See? It can cause, because the pressures are high in the heart, the pressures are high still down here, the vessels can actually rupture, because the more the cholesterol collects in these blood vessels, the small blood vessels inside the brain, they are called end arteries. They are very small and fine. So they are not spared also. So the cholesterol collects also in those. So if the pressures are so high, those patients can actually predispose them to having what we call a hemorrhagic stroke. The blood vessels just rupture, and then they pour blood in the brain because they are very small, they are end arteries, and the pressures are too high, so they just burst open, and then they can cause bleeding. The other thing that, still on the same thing, is that because there is a lot of cholesterol collecting there, we also have changes in the platelets. Platelets are cells in our blood that help us combat bleeding. In case something cuts you, they come here, they aggregate, they cause, and then the bleeding stops. So what really happens is that patients who have diabetic and they have high cholesterol, the platelet functionality is a bit disturbed. So you're going to have an abnormal way they do their function. So predisposing them, they can aggregate, and then they can form a clot. And then that clot, remember already the vessel is small, and then you have a clot in there, and then the blood vessel is a small blood vessel that goes to the brain, particular part of the brain, and it has no collaterals, no other branches that supply it. The moment that part is blocked off, the other part of the brain is going to die away because it's not going to get blood. So that's how someone can end up getting what we call an ischemic stroke.
Why is it important for an ordinary person to know their diabetic status, or to know if they have diabetes at all?
It is important for any ordinary person to know their diabetic status or their blood glucose status. It is very important. In hospital, we usually say that everybody is diabetic until proven otherwise. So not until you monitor or measure your blood sugar, you are actually diabetic. The same applies to hypertension. The moment you clock 40 years, even in the young, they have the young people who actually have hypertension. So you need to always be on the lookout, especially for those who have a family history of both conditions, hypertension and diabetes. So it is important to know, because most of these conditions like hypertension and diabetes, sometimes, or most of the times, people are walking around with these conditions, but they don't have symptoms. They don't have the symptomatology for the classical symptoms of diabetes. They don't have the symptoms of hypertension. And it's even worse for hypertension, that someone can even have high blood pressures, can even have stage 2 hypertension, yet they're having no symptoms, and they're walking around with blood pressure of 220 out of 120, and they are fine. So it is important to always check these blood pressures. What we usually ask, or what we usually do as health workers, is that all patients who come into the clinic, all patients who come into our rooms, all patients who come to hospital, they have to have their vitals measured as a must, whether you like it or you don't, because that may be the only chance that we have to save your life and to avoid complications that may come or that may arise from these two conditions. So it's important that we monitor our blood pressure, we monitor our blood sugar at least once a year. For those who know that they're having a positive family history, your father, your mother, your close siblings are having diabetes or hypertension or both, you need to be more careful, and you need to monitor these vitals, the blood sugar and the blood pressure. Yes.
I went to the hospital recently to do my annual checkup. And while we were doing the numbers, checking, the doctor told me that my blood sugar was elevated. Now, I had gone in to see if I can get a new prescription for my eyes, okay? So when they checked the machine, for the eyes and checked the blood sugar and saw the blood sugar was elevated, the doctor said, we cannot deal with the medication, we cannot deal with the lenses for the glasses, we need to check the diabetes first. Why did they do this?
First of all, I have to commend the clinicians who worked on you, because it is a very good strategy. Because you don't deal with the effect of the diabetes. You deal with the elephant in the room first. The elephant in the room at that moment is diabetes. It is the one that is actually causing the blurry vision. It could be something else. Someone can have diabetes and they have cataracts. It's possible. Two different things. However, because diabetes is well known for causing visual impairment, we have to deal with that first, and we take it out of the way. So the reason why the doctor recommended that you first come and see a physician to sort out and handle the diabetes first, before they can go ahead to give you maybe glasses that you had come to pick, is that oftentimes, and I'll attest to it, most of my clients, majority of them come with blurry vision. And when they come to me, I manage their diabetes, I optimize their care, their vision improves. In fact, there's a young man who came to my attention about 3 years ago. He was about 22 years. He came in the diabetic crisis. He had diabetic ketoacidosis at that point. He was about 22 years, so he didn't know that he was actually diabetic. However, when he came in the classical symptoms of diabetes: increased urination, thirst, weight loss. Of course, when I saw him, he even had glasses that he had been putting on for about 4 months. So when he came to me, we managed the diabetes, we admitted him, managed the diabetes, and he got better. Later, we discharged him on insulin. When we started him on insulin, about 2 weeks down the road, his vision actually improved markedly, that he went off glasses up to today.
Wow.
So it is a very good approach that you start with managing the diabetes, and then we see. If the eyes don't improve, then possibly you can look at other issues that could be affecting your vision and your sight. So what usually happens in diabetes and retinopathy, retinopathy comes from the term retina. Retina is the net behind the eye where the photos, if I may say, or the images fall when you look. So what happens in diabetes is that it's going to cause the blood vessels behind the eye to bulge, and oftentimes they can actually rupture and pour blood into the eye behind. Also, diabetes can also cause retinal detachment, that the retina, the net, is detached from where it's supposed to be, meaning you're going to have worsening visual issues. The moment you come to hospital and we monitor and we find that your sugars are high, we have to make sure that we control your sugars, make sure that the sugars come down, make sure that we optimize, if you're hypertensive, we manage the hypertension, we control the diabetes, control the cholesterol, plus other things, the diet adjustment, the monitoring of blood sugar, and all the others that fall in place. And then when we do that, then the vision actually improves. So the reason why they are not in a hurry to give you glasses is that even if they give you glasses and they have not dealt with the diabetes, the vision will actually deteriorate if it is the diabetic retinopathy. So it is important that the diabetes is dealt with fast. When the sugars stabilize, oftentimes the vision also improves, and you actually don't need the glasses in the long run. Yes,
that's interesting. So I need to call the doctor and thank them, I guess.
Yes, please.
Okay, so so based on what you're saying, with care, the diabetes can be reduced or reversed so that, for example, the vision gets better, okay? If someone does not catch this and they continue living the lifestyle they have been living, what are I would say, the most extreme consequences that someone who has diabetes can experience if they don't check it?
Okay, thank you so much for that question. It's very important. And the reason why it's very important is that it has a bearing on the financial, it has a financial bearing to that person who is the patient. But not only him, people actually forget that they live a sedentary lifestyle, they do whatever they want to do, but they forget that when they get sick, the impact is actually not on them because he's a patient. For him, he's not in the equation anymore. He's on the bed, admitted. However, it is only the other caretakers who have to look for the money to take care of this person who may be even in ICU. So, to answer that question, back to that question, what are the consequences of diabetes? The consequences of diabetes are broadly divided into two. We have the macrovascular and the microvascular complications of diabetes. Micro and macro, from the word macro is big, micro is small. Vascular comes from vessels, blood vessels. So we're looking at the macrovascular complications, which is big blood vessels. Blood vessels that supply the heart, that is the coronaries, coronary arteries, and then the blood vessels that supply the brain. The carotid vessels that take blood to the brain, among other blood vessels inside the brain. Then the microvascular complications are looking at the small blood vessels that run along with the nerves, the vasa nervora and those bundles. But also, we're also looking at the small blood vessels supplying the kidneys, and also the small blood vessels that supply the eyes. So the complications are going to be divided into two, but they're about 5. So under the macrovascular complications, we have complications like a stroke, which can be divided into 2. It can be a clot in the blood vessels in the brain or the carotids, or it can be a bleed. And then we have a heart attack or acute coronary syndrome, which can be either unstable angina, whereby someone gets pain on rest or during exercise, or someone can have a myocardial infarction. So those are the macrovascular complications, and both you wouldn't want to have them because they can actually take life and they can have a bearing on the general well-being of the patient, but also the family as a whole. Then looking at the microvascular complications, I'll start with the neuropathies. Neuropathy coming from neurons, nerves. Yeah? So this is disease of the nerves. So diabetes can actually cause disease of the nerves. The more the sugars increase in your blood, the sugars are going to be converted later into sorbitol, which sorbitol is actually toxic to the nerves. So it causes damage to your nerves. So that damage to the nerves are going to cry. And how will they cry? The nerves are going to cry by causing pain. The pain is usually in the night when you're sleeping. There's burning sensation, there's pricking sensation, pins and needles in the feet, but it may also happen in the hands. So that's one of the things. So when you hear someone telling, I don't sleep at night. When I sleep in the night, I would rather sleep with a bucket. And I put my feet in cold water. Sometimes I even put ice. I get some bit of relief. Mm-hmm. That means the burning is because the nerves are sending a signal that it is bad this side. We need help. The other microvascular complication is the retinopathy. Retinopathy, as we have explained, but you have already explained it. So it's something to do with the eyes. Mm-hmm. Blurry vision. Later, it can actually progress to permanent blindness. If we have rupture of these vessels in the eye, complete retinal detachment, most of these things have no solution to them. Mm. So the earlier we diagnose them, the earlier we catch them, the better for that patient. Mm. And actually in the long run, it is cheap. Because if you catch someone with a retinopathy early and you manage their diabetes and it is reversed, you catch someone with diabetes, they're having some degree of kidney injury, and then you manage their diabetes and their kidneys stabilize, you prevent them from progressing to kidney disease, which will actually be very expensive for them in the long run. Mm. So those are our biggest worries. And that's why we are, as physicians and health workers and clinicians, we are always on the lookout for this condition, especially diabetes and hypertension. Mm-hmm. So when they come, we have to assess, rule out all these complications, screen for them. So I still advise that whenever I go to hospital, and possibly the doctor says that you're hypertensive or you're diabetic, sometimes we're a bit rigid as patients. You come to hospital, say, doctor, I don't want to be checked cholesterol. I'm small, I'm only 50 kgs. Where did I get the cholesterol from? Why are you wasting my money? I urinate well. What is the problem with my kidneys? The reason why sometimes doctors ask for what we ask for is because it may not be that the kidneys have a problem today, but we want to see how are they now. In case there are any issues, when we follow you up, are they progressively worsening? Are they improving? They were okay after 3 months, 6 months. Why are they worsening? So it's important that as patients, when you come to hospital, try as much as possible to follow the guidance of the doctor. Of course, it's important that you ask questions to your clinician or to your physician, the reason why they want to do certain things, so that you know what they are going to do. But it's important that they get checked early. Never go to hospital and the doctor does not assess your heart, you're hypertensive, doesn't take your blood pressure. It's criminal. Those have to be done. Mm-hmm. Hypertension has to be assessed. Diabetes has to be assessed. They have to check your cholesterol. They have to check your feet. That we do on a daily in the clinic. People don't want to check people's feet. But it's important because the problem could actually be there. Someone is talking about they are not sleeping in the night. They're having a lot of pain. They're having a lot of burning. The other thing that I would also want to talk about concerning the microvascular complications, especially the neuropathy, it has two types. We have the peripheral neuropathy. We have it could be neuropathic, it could be vesicular. And both extremes can happen in diabetes. So you've had people come into hospital, they are diabetic. A few years down the road, you hear, they have been amputated. Their legs have been cut off. So usually the reason why their legs are having issues is because possibly the sugars are poorly controlled. Maybe they have lost follow-up, and then the sugars are skyrocketing. Maybe they are not on drugs. Maybe they're on drugs, but they're not effective anymore. And then the neuropathy is worsened, and then they end up getting issues. The long-term problems of diabetes are basically someone can actually go blind. You can lose your limbs. You can get a heart attack. You can get a stroke. All those are complications. You can also get kidney disease. And you've had people going on dialysis because their kidneys have issues. So you can have kidney problems along the way because of poorly controlled diabetes.
There is I would say, a myth, or maybe it is a misconception, I don't know, but an understanding that people who are big or fat are the ones who are going to get diabetes, and people who are small or thin do not have diabetes, or that it is only among the elderly as opposed to young kids or young children. Is this correct?
This myth is actually not correct. It's actually not correct. There are quite a number of studies that have been done locally by Dr. Chibirige et al. And Dr. Lumu William et al. And the statistics have shown that actually in Uganda, we have the lean type of diabetes, meaning that someone has type 2 diabetes, but actually small. They are not big. So it's the reverse. So in Europe and the US, majority of them have type 2 diabetes, which is usually linked to obesity. We still have it here, yes, but majority of our patients actually have the lean type of diabetes. So someone being small does not guarantee you that you're actually having free from diabetes. You could actually be having diabetes despite the fact that you are small. Bearing in mind the research that have been done locally, telling us that you're actually having a lot of lean type of diabetes as compared to the obesity. So patients who are obese are more predisposed to having diabetes, definitely, because of insulin resistance. So we always try as much as possible to advise our patients to cut down on their weight and reduce their BMI, to see that their BMI is within normal range, and their diabetes oftentimes, in a few patients, they can actually go into remission if they are really serious about their weight. So for patients who are lean, we have talked about them. The other category of people are those people who may not have all the symptoms. They are urinating well. They're not urinating a lot in the night. They are not having too much thirst. They're not drinking a lot of water. But they may have the catch may be on their weight loss. They don't have any other symptoms. They are going about their activities where they have some degree of body weakness, which may, you may say, I'm working a lot in Chikugu, I'm tired, and maybe it could be fatigue. But the catch is in the unintentional weight loss. You've been weighing maybe 100 kilograms, and about a month down the road, you notice that you're 89.
And you didn't work out.
You're not working out, you're not gymming. Start to question yourself. Because unintentional weight you don't just shed off weight like that unintentionally. So that may be the catch. So you need to observe and see. So I will still talk about, looking at what you have just talked about, I will still talk about what are the cardinal symptoms, coupling it with the question that you've asked. How would someone say that they actually diabetic? What would be some of the symptoms that would actually show or manifest for someone to really start to think, I may be actually diabetic? There are about 8 things or 6 things that we look at. We call them the 5 Ps and the 3 Ws. So if you notice that you have unintentional weight loss, you notice that you're having weakness, unexplained. You walk from here up to there, you feel weak, you feel tired unexpectedly. You're having increased urination, especially during the day. It may be a bit hard because you're drinking, taking some soda, you're drinking water, you're drinking juice. So it's a bit cold. So you may say, maybe it's because of the weather. That's why I'm frequenting the loos. So it may be hard to assess. However, in the night, that's when you know. That's where the catch is. Because in the night, you wake up to pee more than 3 times, and that will be abnormal. See? So increased urination, especially in the night, increased thirst, you drink the entire night. You can even drink 5 liters of water. And some people may actually say, but it is healthy, I feel like the doctors tell us to drink water. May actually drink 5 liters.
And they're using it as a defense, not actually confirming that this is a symptom of the thing we're talking about.
So that you may not know. So maybe they are the only symptom that is frequent intake of water. You're taking too much, you see? The other symptom that you could have is body itching, pruritus, generalized body itching. Of course, is coupled with others. See? Yeah. Then the other, in the men, this is a catch for the men. When you notice that issues are not going on well at home, it may be an indicator that you're actually already diabetic. Because diabetic is the leading cause of erectile dysfunction.
Really?
So the moment you notice that you're having issues, go for that check. Go for that blood sugar test. It may be the reason why it is happening. The science is clear. Why would someone have erectile issues because of diabetes? The diabetes is a pro-inflammatory disease or condition. So there's a lot of inflammation going on, and this inflammation is going to cause damage to the blood vessels. And the physiology of that organ is that for it to perform and work, you have to have increased blood flow to that organ. So if the blood vessels are already damaged and they're having issues, the blood flow to the organ is going to be inadequate. So you're not going to be able to perform your duties as a man. So you may have a few of the patients may come with the cardinal symptoms of increased thirst, increased urination, weight loss, weakness, maybe body itching, and increased hunger. But for the layman, if you notice that you're urinating frequently, especially in the night, you notice that you're eating a lot, you've eaten fene. The next day you're passing muchomo, you eat it. The next day you're eating gonja, you eat it. So you feel like you're not getting satisfied, you're eating all the time. That could be an indicator that something wrong is already happening. So those are some of the things that we look at, not forgetting the kusanyalala in the feet, the burning sensation, the pricking sensation in the feet, and also the blurry vision. So we have talked about the adult diabetes broadly. Now in children, children can actually be affected by diabetes. And mostly in children, we used to see a lot of type 1 diabetes. That is children losing a lot of weight, having all the symptoms that you've talked about, and then coming in with, especially, sometimes they usually come in crisis. They have a diabetic emergency. Sometimes they can come in a diabetic coma, and then you have to admit them in ICU. So children can also be affected by diabetes. So majority of the children actually have type 1 diabetes, which there is usually a genetic predisposition, and there is a family history of diabetes when you track back. So children, rarely do they get diabetes, but they can actually get it. And it is more common in those who have a genetic predisposition, but also those who have a family history of diabetes at home. Those can actually have type 1 diabetes. I'll later on talk about some brief science concerning this type 1 diabetes. Children, rarely back then, especially in Africa here, we used not to see a lot of type 2 diabetes that you have talked about that usually happens in the adult because of the sedentary lifestyle, what we eat, the smoking, too much alcohol consumption. Because when the children don't smoke, when the children don't drink alcohol, then where are they getting all this extra weight from? This could actually be because of 2 things or 3 things. Number one, still sedentary lifestyle in the children.
Yes, playing video games.
Back in the day, we used to have a lot of space where we used to play from. You know, there was space for a playground. You would come from school, go to the football pitch, and you play. You know, play netball. The girls would play netball. The boys would play football, rugby. You know, there was space for playing. And fields. Even at home, you would actually play, whatever, jump, skip a rope, you know. But now, things have changed a bit. You notice that a lot of children are indoors. There is no space for playing. They're in the house all the time. If they're not at school, they are in the house. If they are out of the house, they are in the malls. So they don't exercise at all. And we are also seeing a lot of obesity in the children. So this obesity is actually pushing them into type 2 diabetes. And this obesity is basically being brought about by the food that they eat, eating a lot of junk, drinking a lot of carbonated drinks, and they are not doing any exercise. So a couple of those factors actually can push these children into having type 2 diabetes. I will surprise you that mothers who give birth to children of low birth weight, oftentimes those children actually later on develop type 2 diabetes because the child is very small for age, the mothers tend to feed them a lot, tend to pamper them a lot, and they put on a lot of weight. And along the way, they can get predisposed to having type 2 diabetes. Logically, you can think about it and say, okay, my wife has given birth to a 1 kilogram baby. This baby is very small. We have to feed him.
Yes.
And then after 2 years, the baby comes back and is 12 kgs or 15 kgs, which is very abnormal. So we don't really recommend that. But that is really one of the other side effects of what? Of diabetes in the children. So if there is a positive family history of diabetes, and there are 2 or more close relatives who have diabetes, you need to make sure that the children are tested. Some of these tests are a bit expensive because you may test a child and they don't have any symptoms of diabetes. You check their blood sugar and it is okay, it is within normal range. But you know at the back of your mind that this child of mine may actually be having a predisposition to diabetes. So what we usually recommend for that is for patients who have type 1 diabetes, we recommend that they have these insulin antibody screening tests done. They're about 3 or 4. So in the children, usually recommend that they do the IAA. These are a bit technical, but they're actually out there, but they're a bit expensive. So if you're a parent, and you know there's a positive family history, and you're worried about your child actually advancing to get diabetes, you can just go for a screen of your child. They can have these antibodies tests done. The insulin antibodies, IA2, the zinc transporter 8 antibodies, the anti-GAD65 antibodies, and the IAA antibodies. In the children, we usually recommend doing the IAA and maybe the insulin isolates antibodies. The others, the zinc transporter 8 and the anti-GAD65 antibodies, usually leave them for the adults whom we think may actually be having type 1 diabetes. But in the adults, because it can also manifest later in their teens, but also in their 20s or their 30s. So not everybody who has diabetes and they are over 20 years, this must be type 2. They should actually be having type 1.
When it comes to the foods that diabetic people can and cannot eat, or should and should not eat, what do you have to guide about this?
I'll divide it into 2. I'll look at the children and the adults. Briefly, the children, you don't really restrict them a lot because they are still growing. They need the carbs, they need the protein, they need the vegetables, the vitamins, and the minerals for their growth and development. So we're a bit relaxed with the children. Now, when it comes to adults, they're already grown up. So we don't expect a lot of growth in terms of physical, growth. So what we usually recommend, back in the day, we used to tell our patients, they went to a diabetic, stop posho, stop rice, stop matoke, stop pumpkin, stop this. And the patient asks you, doctor, what am I going to eat?
Yes.
You're only going to eat fish and maybe beans and peas together with maybe a small portion of matoke. But let's not forget that Uganda is a blessed country with a lot of food that is rich in very many minerals. And we have different tribes. You may be a Muganda and your staple food is matoke. I may be an Arul and my staple food is maybe kalo, that is millet, and posho. I may be coming from Kenya and I take ugali. So, and you're telling me I take off all these carbohydrates. I don't eat matoke. I've never eaten matoke my entire life. So how would you go about these patients? So we noticed that we were a bit strict and hard when it came to food and diet in our patients. However, we came to terms that, okay, we are going to allow you to eat most of the things. However, some are a no-go zone. Others you can eat in moderation. Others you can take the way you want. Now, it is a broad topic, but I'll break it down in this way. We look at our hands. We usually recommend that these two hands should be a portion of green vegetables.
Okay.
Vegetables should be filled up in your hands. Graphic representation. Protein should be the size of your palm. Protein could be fish. It could be meat that doesn't have fat. It could be chicken that doesn't have skin. The size of your palm. We used to say, don't eat butter, don't eat cheese. But someone may have a craving for butter. Blue band. We say, okay, it is okay. The tip of your finger should be, just start to take away the craving. Just the tip of your finger should be the butter or the cheese. It could be butter, cheese. The portion, the carbohydrates. The portion of the carbohydrate should be the size of your fist. So that includes rice, that includes posho, that includes cassava. Only your fist. And we recommend at least one carb. Don't add 2 or 3. So if you're to do a carb, have a portion of posho. Don't add posho, rice, cassava, no, millet. Choose one of those carbohydrates. After you've chosen one, have your sauce, and then have your vegetables. So we usually recommend that if it's a plate, half of that plate should be greens. The other half, divide it into 2. One half is for the sauce. The other half is for the food. Now, having said that, someone will say, but doctor, I love potatoes a lot, because I've not talked about them. Now, potatoes, especially the sweet potatoes, they have a low glycemic index. Their sugar content or the calories are low. However, the condition should be that the sweet potatoes should be freshly harvested from the garden, and they should be boiled. The moment you bake or smoke that potato, the glycemic index is going to shoot exponentially. And when you take it, your sugars will skyrocket. So the teaching is, or the way to do it is, go to the market, ask your vendor who supplies you, I want potatoes that are freshly harvested. So when they give them to you, you boil them. You can have your sweet potatoes, have your matoke, maybe a bit of rice, and then your sauce. Secondly, there are people who love rice a lot and they cannot do away with it. It's okay. You can have it in full portions. However, I'll put a disclaimer. You have to wash it more than 4 times. Washing that rice means you're throwing away all the sweetness, because the sweetness in the rice comes from the starch. And the more you rinse it, the more the sweetness goes away. So it may not be very palatable, but that's what we want. Because the more you take, when you take a huge portion of rice with all its starch, the sugars will skyrocket. But if you don't want to wash it, it's a bit cumbersome. Just take a very small quantity of rice. Yes. Still on the foods, I'll comment about the fruits. Now, there are fruits that every fruit has its own glycemic index, or their calories. A no-go zone when it comes to the fruits, the first is the pineapple. Actually, the first is the watermelon. It tops the list. Watermelon. It has a very high glycemic index, and the more you take it, the more the sugars rise. Yes, especially for patients who are diabetic. The second is the pineapple. See, the other is very ripe jackfruit, very ripe pawpaws.
These are the fruits that people really like. These are the fruits they like. Eh?
See? And red apples. So, and sweet bananas. I'll use the local language. We have the ndizi and the bogoya. The bogoya is the bigger one, the big bananas, the sweet ones. And then the ndizi is the small ones. The small ones have very high sugars, so we don't usually recommend those ones. We recommend that you take the bogoya at least one a day. So the question will be, what fruits am I going to take? You can take cherries, you can take berries, you can take green apples, you can take a mango, possibly a slice of mango. You can take some bit of papaya, but it should be a bit semi-raw, not very ripe, not raw, a bit semi-raw.
Halfway there.
Halfway, yes. Now, the source. All plant protein is good.
So beans, peas,
yes. Nuts,
yes.
all those are okay. Plant protein is okay. It's okay. You can have it in whatever quantity you want.
What about people who say boiled food is good? You know, you've mentioned some of the things, but they go and eat, what is it called? The feet of the cow. Right? They boil that one and take the soup out of that. Is that okay?
It depends, because the foot of the cow has a lot of fat. That one I wouldn't recommend it. Yes, it has a lot of fat in it, too much. The best, if you talk about protein, if you leave alone the animal, the plant protein is okay, it's a pass. But the animal protein, the best is fish, especially the scaled fish. Tilapia, even Nile perch is good. The small silver fish is also healthy. Mokene and nkeje from our local language here. So all those are fine. Now, the meat, some of the meat people like a lot. Meat has a lot of fat in it, and that fat is saturated fat, so it's not very good fat. So we say you can have the meat, but don't have it every day. And don't eat the fat in the meat. Just eat the meat itself.
And not a whole plate.
And not the whole plate of meat. Yes. Chicken is excellent. However, we all know we love the skin of the chicken. It gives you that taste. But one day, just open that skin and see the amount of fat below that skin. That fat is too much. So what we really recommend is that take off that skin, put it aside, eat the meat alone, minus the skin. Yes. The other no-go zone is in certain fats. For example, ghee. Ghee is a no-go zone. A sharp way for our colleagues in the West. Please, that is also a no-go zone. That one is also a no-go zone. If you want to do some bit of frying, I would recommend that you use vegetable oil. Olive oil is still very excellent. You can do some bit of frying with it. And sunflower oil is also excellent. It has most of this oil is actually plant oil. It's vegetable oil, other than the animal oil that we see in ghee and the other saturated fats. Yes.
There is also, usually they'll say that instead of taking the sugar, the normal sugar, that you can take honey as a replacement. Is that true?
That is not correct. That is not correct. Especially for people who have very high sugars that are poorly controlled. We usually recommend that stay away from the sugar, stay away from the honey. The body has a mechanism of adapting, only that we always fight it. But the body adapts, and it adapts very quickly. So when you take that milk the first day with no sugar, you take that tea, take that coffee with no sugar, it will be a bit of a challenge because you've been taking sugar or honey all your life. But a week, 2 weeks down the road, you'll be okay. You'll be okay. So honey, sugarcane, all those will actually, even the other thing are dates. Those plants that are called dates. Very high concentration of sugar.
How about grapes?
Grapes are okay.
Grapes are okay.
Grapes are fine.
Both the red ones and the green ones.
Yes, they are fine. They are okay. So sugar, honey, let's first wait. However, when your sugars are at target and you're moving pretty well, your sugars are stable, your blood pressures are stable, usually by that time you have already gotten used to taking tea without sugar. So by that time you may not have, that may not be a concern to you anymore. The other thing that I also want to talk about is milk. Some of our colleagues, some of our, in our population here in Uganda, we drink a lot of milk, and a lot of it is on the market. However, milk has a lot of fat, a lot of it. So when you take it, it means that you're going to have a lot of fat intake, which will actually worsen your cholesterol. So what we usually recommend is that if you're able to get skimmed milk, it's the best. Skimmed milk is that milk that they have taken away all the fat. It has zero fat, but it has all the other components and essential nutrients in the milk. That is very good milk to take. But it's a bit expensive and a bit rare on the market. But most of the big supermarkets actually have it. This milk that we are talking about from our cows is still okay, only that it has that fat. So if you can't access, the skimmed milk, what you do, you have to dilute that milk, a ratio of 1:3. So 1 cup of milk, put in like 3 cups of water, and then you can take it.
Wow.
And then after, during the cooking and that fat layer is up there, remove it. Comes
So
up,
really what you're saying, just stop taking milk, because diluting milk by 3 units and then skimming the cream, it's no longer milk, it is water, colored water at this point.
I know. That is the science that can actually lead to all the complications. Yes.
Do you feel as though people take the issue of diabetes, cholesterol, high blood pressure, do you think they take it seriously as it should be or as it is?
I think, yes.
Let me rephrase. When patients come to the hospital and they're talking to you, when you explain to them the issue, the feedback that you get, do you feel that they have really understood the gravity of this issue, or do you feel they are taking it lightly and they will be able to overcome it?
I'll answer it in this way. Not everybody is aware. The awareness of these 2 conditions is a bit wanting, especially in our country, but also globally. More so because hypertension and diabetes oftentimes don't actually cause pain. So if someone feels they have no pain, they have no what, as we said, someone can be diabetic for 7 years and they don't have any symptoms. By the time they come to start hospital, they start feeling symptoms after 7 to 10 years. See? So because they don't have any symptoms, they really don't, they just hear it as diabetes. Me, I'm okay, I'm even small. Where would I have the hypertension? Why would I have the diabetes? So the gravity of the issue is not well known because the awareness is still wanting. As Uganda Diabetic Association, we are really working hard to see that we bring to light some of these conditions, making people aware that diabetes is a killer, hypertension is a silent killer, and these are some of the things these are the consequences if they go undiagnosed, if they go unchecked. Yes. So to answer that question again, are people aware about the gravity of the 2 NCDs or more? Is that not so much. Not so much people are. I don't really think people are aware, especially in the rural areas where they don't have access to some of the things that people have access to, especially in the urban areas. Yes, because in the urban areas, people have televisions, people have radios, people have phones, but people in the rural areas, they may not be privileged to have some of these devices, so they really don't attach value to some of these things, even if they come. Most of them may actually think, as you say, they talk about the myth, they may actually think, I'm being bewitched. Yet someone is actually having diabetes, the cause of their problem. So there is still need for awareness. There's still need for outreaches. There's still need for people to get to know that there's actually this problem. I think still the government needs to come in handy here. The same way the government came in handy to bring awareness as regards HIV and even its care. I think we still need the government to come in because we are seeing a lot of people having this condition of diabetes and hypertension. I will tell you that we have over 462 million people globally affected by this condition called diabetes. And the prevalence of diabetes in Uganda is at 0.4 to 9%. And we still feel that is an understatement because the research methodology, the people doing research, not many people are doing it. So if we do the research that is required, you'll find that this number may actually be even higher because the numbers that are coming to the clinic are overwhelming. So we still need the government, we need the NGOs, we need and other institutions to come in to really sensitize our population, especially in Uganda, about the growing numbers when it comes to diabetes. Almost half of the people are not aware that they're actually having this condition. So you notice that people are actually not aware. Even those who are aware, it is a very small portion of them who have actually taken the initiative to start on medication, to be tested, to start on the medication. Very few people. So we need the government to come in handy. We need the NGOs to come in handy. We need sensitization of our general population. And even in the health centers, back in the villages, they need to be educated on these conditions. Resources have to be availed. Blood glucose machines, blood pressure machines, all those things, they are very simple things, but they can actually make a difference and they can test early, diagnose early, start treatment early, and then the rest is history. We shall prevent complications later. You see? Because the complications that come from these two conditions, they are enormous. They have a bearing on the families, they are very expensive, and they can actually have a financial implication, a very big one, to families, but also on communities, and also a nation generally.
How important is exercise when it comes to diabetes and high blood pressure management?
Exercise is extremely important when it comes to diabetes and even hypertension. Actually, while managing hypertension or diabetes, even both, but diabetes in particular, we usually recommend that make sure that they exercise, number one, number two, diet, and then you notice that our drugs actually come last. So exercise is extremely important for both hypertension and diabetes. The question would be, what kind of exercises should one do and how do they do them? I will tell you that people actually, the way they do the exercise, when you try to ask and probe, they will tell you, doctor, me, I do exercise. And you ask how? So, doctor, me, you say every Saturday, I go to the football pitch. I start playing football from 8 to 9 p.m.
Every Saturday.
And then on Sunday, I go to church, I finish up with work. Then on Monday, I start my week. And yes, they have actually done exercise. And it is actually vigorous. Vigorous, very vigorous. But that is not the right way of doing exercise. Because that kind of exercise is only going to give you muscle pain and discomfort on Sunday and Monday. But we usually recommend that someone should actually have about 150 minutes of exercise per week. That comes to about 30 to about 60 minutes of exercise daily, a minimum of 5 days a week, never to go more than 2 days without doing exercise.
Wow.
30 to 60 minutes. You don't have to be strenuous. You don't have to take it slow. The most important thing is not the quantity of the exercise. It's not the amount of exercise that you do or the duration that you take to do the exercise. The most important thing is the consistency. That is where the catch is. Small steps every day. It's the same. The logic is the same, even with success, even with what? Small steps every day lead to success. The same happens even in diabetes management. Small steps of exercise, shorter duration, but every day, at least 5 days a week, 30 to 60 minutes a day will actually yield you results. And what kind of exercise do we recommend? We recommend aerobic exercises. It could be yoga, it could be stretching, it could be skipping a rope, it could be brisk walking, it could be swimming, it could be, running, jogging, swimming. All those exercises are actually very important. And they're healthy for the heart, but also for the general well-being of the body. They reduce cholesterol, they help cut down on the reduce glucose resistance that we have been insulin resistance that we've been talking about. They improve the general well-being, the circulation of the blood. It is magical. It is actually magical. So it is important that someone does exercise as prescribed. Actually, exercise is prescribed.
It's a prescription. For a diabetic patient.
Yeah,
Number one prescription.
You prescribe. You don't tell a patient that, you go and do this. You prescribe it. I want you to skip a rope on Monday, 30 minutes. Go for swimming, 40 minutes. You prescribe the exercise. But you recommend, as the doctor prescribes, you can have, because we do different work. Of course, as we're talking to patients about this, we try to see how we can fit in their day-to-day work and activity. Because someone will tell you, Doctor, I work at night, and during the day I'm resting, and then you're telling them to run at 8 a.m. So you have to talk to the patient. We usually talk to the patient, and we advise them that as you're doing the exercise, when are you free? When are you having work intensity? Those days, 2 days, you can relax, and then the other days that you're a bit free, you can do them. For those who are able to afford, you can actually have a treadmill at home. You can have a stationary bike at home at your convenience. You wake up in the morning, you do your exercise, and then after that, you go about your day-to-day activities. It will be a plus for you. We recommend resistance training about 2 to 3. We don't recommend it. It shouldn't be intense as the aerobics. Resistance training is lifting. You lift the weights. Yeah, at least on two occasions. Yeah,
2 days a week.
2 days a week.
Okay.
2 days a week. That's what you recommend. That 2 days a week you can do some bit of lifting, but majority of the other days you do aerobics. They are very good for the heart. As I said, they improve insulin resistance, they improve blood flow, they also improve the general well-being. They keep you in shape. But of course, you will not see the change in the shape in a week. But as I said, the consistency. You will see the results later, 2 months, 3 months down the road, you start to see the results. And it actually becomes a habit. Because initially it will be a struggle, but when you persist and you persevere through it, it becomes a habit and it becomes part of you. Remember, initially, you're pushing to start. Feel like, leave this bed, how can I leave this bed? But then, along the way, now the body starts to ask for it.
True.
But you guys, you have not done exercise.
True.
You feel unwell.
True.
You feel unease. And then you have to go for it. So, make it a habit. Along the way, it will be a smooth ride for you.
True. And the more you're exercising, you're reducing that fat barrier.
Exactly.
From protecting the muscle.
Yes.
Therefore, now your insulin can now go
smoothly. Yeah. So that's the insulin resistance I've been talking about. Because it will help reduce on the fat, and then the movement of the insulin and the glucose into the tissue is going to be very, very adequate. Yes. Actually. I didn't want to say this, but let me say it. Someone can actually go into remission of diabetes. But
what does that mean?
Remission is whereby someone is diabetic, they have confirmed that they are diabetic, we start them on treatment, we advise on lifestyle modification, they stop smoking if they have been smoking, they take off alcohol, they adjust their diet, they do exercise regularly to that dot, and then they take their medication. Along the way, their sugars actually drop
to normal
ranges. And when they drop to normal ranges, you notice that, okay, you've been taking 4 tablets. Let's do 3, normal. Let's do 2, normal. Let's do 1, normal. Let's do half, normal. And then you're like, should I take them off?
You're even skeptical. You're not sure at that point. It's like, if I take him off and the man
then the man gets, But actually, someone can go into remission, and we can actually take you off. The moment you notice that you are into remission, we advise that, okay, let's give you a holiday. You've been taking these drugs religiously, but you notice that your sugars have consistently been normal, despite us reducing on your drugs. Both maybe insulin, maybe oral drugs, been reducing. Now, along the way, we say, okay, let's give you a drug holiday for maybe a week, but monitor the sugars. And when you monitor your sugars, what is that? Even off medication, sugars are good. 4.8, 4.5, 5, 5.2, normal blood sugar. That is for the fasting. The postprandial blood sugars are 6, they are 7, they are 8, they are normal. Even after 2 hours after meal, they are 5, and they're doing well. So we start to think, okay, possibly you are into remission. So it may give you more time, give you more time. But we usually recommend that even if you're going into remission, please always make sure that you do these 2. Those ones are a must. Do exercise to the dot. Continue the lifestyle modification. Stop smoking, stop alcohol. Do the diet the way we are doing it, the way we are advised to do it. Because if you go into remission and then someone says, the sugar's chewed. There are patients who come to me and say, doctor, no, actually for me the sugar is chewed and I don't have diabetes. So those patients actually, they go off drugs and they are okay. But that does not mean that see, they're just either remission and honeymooning are almost the same thing. They're either honeymooning or they're actually just in remission. So when they go back to their normal lifestyles, actually diabetes comes back. Full blown.
Like they say, when you stop exercising at the gym and you relax,
all the weight
comes back.
You pull it back, all the weight.
Is there some stigma around having diabetes? Do you find this to be the case?
Stigma around diabetes among the population.
Yes. Or well, I guess it is also denial, but stigma really, that people who have diabetes are looked
stigmatized and what? I have not seen that, even in our general population. If I'm to compare diabetes and HIV, despite the fact that actually HIV is well managed, someone takes their drugs, they are good to go. Because of the support and all those things, and the drugs, So HIV actually has more stigma as compared to diabetes. The stigma in diabetes may come, it is there, but it's not the magnitude of the other conditions like the HIV. I will compare that too. But where the stigma will come in, if someone has diabetes and maybe their children get diabetes, now the stigma may come in there. Because if the children have diabetes, the other people will say, now that family, the moment you go there, you're finished. All your children are going to have what? Diabetes. So the stigma may actually come in that line. That the moment you go, those people, that family actually has diabetes. So even if you have a son who would want to get married to maybe a lady in that family, you would stop them because you're worried about the offspring acquiring what? Diabetes, which could actually be true. Because if someone has already a family history, there is a possibility that the children may actually have diabetes also. So with that, there may be some bit of stigma. But it is not so open as regards to other conditions. Because people openly talk about it. I have diabetes. Openly. But nobody will say that I have HIV.
No.
So it is there, but to a certain degree. And when someone has diabetes, they sometimes sympathize with them. They are, the stigma is not as much.
So from what I'm hearing, the medication for diabetes will be taken as long as the blood sugar is high. When the blood sugar comes within range, there is a possibility of temporarily taking you off as we monitor the sugars. If they maintain, you maintain off. Does it mean that at certain point in future, a person who is diabetic might actually get off medication?
I will say that diabetes and hypertension, the moment someone clocks in, they can't clock out. That's the unfortunate bit. The moment you diagnose with diabetes, that is it. Someone is going to be on drugs for life, ideally. However, there are those outliers, people who honeymoon or who can actually go into remission. For you to know that someone may be going into remission is whereby they are taking the least possible drugs, but their sugars are actually even dropping to low levels. Then we know most likely they are either honeymooning or they're just in remission. So at times the pancreas can go to sleep. It can happen. So it goes to sleep and then doesn't produce insulin at all. So if it doesn't produce insulin, it means the sugars are going to surge. So when you bring in your drugs, you know, the drugs help push the sugars into the muscles, then the pancreas wakes up along the way. Hey, I've been sleeping. And then it wakes up, notices, hey, what is going on here? Starts doing its role. When it starts doing its role, the sugars, you're giving your drugs, the pancreas is also working, the sugars drop. So even to the least possible drugs, the sugars are actually dropping. So you notice, okay, this patient, maybe we can take them off and then we monitor. But someone having normal blood sugar of 5 or 4.5 or 4.2, 4.4, normal blood sugar, and they're on drugs, that does not mean they're in remission. It means whatever is causing their blood sugars to stabilize, they are the what? Medication. So you just advise them to keep on their drug. We advise patients or clients to always keep on their drugs and always to go back to their physician for an assessment and all that. You talked about the hypoglycemia. I don't know that I should also talk about it here. Or low blood sugar. We would rather have the blood sugars high than have them low. Because low blood sugar can actually cause sudden death.
Sudden death?
Yes. Because the only source of, remember I talked about the ketones and the muscles breaking down to produce other sources of energy and the fat. The energy that is produced from catabolism or breakdown of fat and muscle is only important for the rest of the body except the brain. The brain primarily uses glucose only, primarily. So if as a source of energy, so you need to make sure that the blood sugars are kept at target, they don't drop. Because when they drop, the brain shuts down. It shuts down. But the more someone gets recurrent episodes of low blood sugar, it has a cardiovascular risk to the heart. Low blood sugar can actually predispose to heart disease because the more the sugars drop, you're going to have changes in the pathophysiology of the blood vessels, impaired flow of blood and to the coronaries. So low blood sugar is a no-go zone. So we always advise clients that when your blood sugars drop, even on one reading, note it down, inform your physician.
And the dropping is below 4?
The drop is below 4.
If you're measuring?
Yes. 3.5, 3.8, 2, low. Usually the body actually senses that there is something wrong going on. There is something wrong in my body. You feel weak, abnormally, sudden onset. You've been okay, you feel weak, you're shaking, you're sweaty, you're getting a bit dizzy, confused. When that progresses for the next 5 minutes, you can actually drop down.
And die.
You may not die at that moment, but because you pass out. Yes, that's the right word I was looking for. You actually just pass out because the sugars are low. The brain is not getting glucose.
So if I'm driving, I'm on the expressway, I have nowhere to park, I feel dizzy and all these things, what do? I could.
It is a risky thing, very risky, because we always advise that patients who are diabetic and they're on their medication to carry some bit of sweets. You may not carry soda or whatever, just have some bit of candies with you. Have them, especially if you're going to go long distances. Have them with you in case you feel unease, because you may be driving, you don't have the time to check your sugars to see. As I said, you'd rather have the sugars high
Right.
than have them low.
Right.
So at least take a sweet or two to give you some bit of glucose. When you reach your next destination, you can, check your sugars and see where am I standing in terms of blood sugars.
When you take this candy piece or soda, whatever, this is like an emergency shortcut to bring you back up. And when you take it, is the effect immediate or does it take some time?
The effect is actually immediate because I'll give an example of the sodas. The concentration of glucose there is enormous. It's too high. Still on the sodas, for those who are diabetic, please never take Coke Zero.
Really?
I'm telling you. Because it doesn't have glucose. It has fructose.
Okay, so I cannot take it as an emergency measure, and I cannot take it at all.
Yes. Remember, already the sodas are out of the equation.
Right.
Already they are out of the equation. But this is an emergency setup. You're somewhere, then you feel unease, and you notice that, okay, it's called hypoglycemic awareness. You are aware that most likely the sugars are dropping. So when you get that awareness, you pick a soda, you take. So these normal sodas of ours, the Fanta, the Coca-Cola, all those actually have glucose and a lot of it. So that glucose goes direct. Because right now we're looking at the brain, they go direct to the brain. The glucose that is, after taking, they get diffused, and goes to the tissues, go to the brain, and then you feel better. However, Coke Zero does not have glucose. It has fructose. So it will actually be converted into fat in the long run, which will be stored on your liver.
Waste of time.
So it's not going to
You could die, actually.
With your Coke Zero. Yes. Because the zero means zero glucose. Yes, the glucose is actually not there. So in case of an emergency, you can do that. The other people is that, the other clients, the challenges that they face that we have noticed is that when someone gets hypoglycemic awareness, they notice that their sugars have dropped. What they do, they get anxious. So they take too much. So they panic, they overcorrect. So instead of taking 2 candies, they take a whole box of chocolate. Instead of taking just 250 ml of soda, they take 1 liter. And then they check after the sugars move from 2 to 30 because they have overcorrected. Yes. So the hypoglycemic awareness is important. Now, what are some of the conditions that actually can cause hypoglycemia? Let's just talk about those. Some of the things that can cause hypoglycemia, of course, drugs, insulin, and some other oral hypoglycemic drugs. There are some that we know that are notorious for causing low blood sugar. Even most of them, or all of them, can actually, they have the potential, because they are anyway glucose lowering drugs. But others have a higher potential of causing hypoglycemia than others. Insulin topping the list. Insulin topping the list. Now, drugs are the first cause of hypoglycemia. The other thing that can actually cause hypoglycemia is people who don't take their meals on time. You had your breakfast, but then you're running about day-to-day activities. You notice that it is 5, you're not had lunch because you're doing A, B, C, D, E. You're feeling hungry, but you're not taking your drugs. But remember, you're taking your food. But remember, you took your medicine in the morning. So those are people actually can also go into hypoglycemia because they have not fed. Yeah. So we usually recommend that someone should take small, the proportions, as we talked about them. At least, have 5 feeds in a day, at least. Have your breakfast.
Meal something.
Then you take your medication, have your breakfast. Then before lunch, you can snack. You can snack on a fruit. It can be an apple. It can be maybe a carb. It could be half a chapati. It could be a samosa or one or two. It could be nuts. Snack on something, maybe at around 11. If you had a breakfast at 6, snack on something at 11 or midday before you go for lunch. Just in case there is a delay, you're covered. See? So for example, if you're supposed to get lunch at 2, and then for whatever reason lunch is served at 3, or you take your lunch at 3, you're fully covered because you had the snack in between. Then you have your lunch. Before dinner, still snack on something at about 5 or 6. You can snack on tea and nuts. You can snack on a banana. You can snack on an apple. You can snack on grapes. Snack on something. So you notice, have your breakfast, snack on something, have your lunch, snack on something, have your dinner. By doing that, the risk of hypoglycemia are markedly reduced. Remember, we don't eat heaps of food. The two are the wumbo. I will put it in a local language. We don't take heaps. You put on a heap of matoke.
So if I have a plate, half of it is vegetables.
Exactly.
I don't like vegetables, maybe. This part of the protein, instead of putting flat meat like this, I put, this is not allowed.
That is not allowed. That is not allowed.
Make the vegetables flat and make the meat a lot.
That is still not allowed. Remember, protein should be the size of your palm. So if your protein can fit on your palm, that's what you put there. Or less. See? The vegetables, the 2 palms. The carb, just a fist. Remember, matoke has water, but it is actually has a lot of carbohydrates also. So don't eat a lot of, because people eat a lot of matoke, thinking that matoke is actually just water. No. Yes, it has the water component, but it actually has a lot of calories in it. So we usually recommend actually only 3 to 4 fingers of matoke.
There is what we call gestational diabetes. What is that exactly?
Gestational diabetes is a condition where a mother previously has not had diabetes at all. No history of diabetes. She's not diabetic, but then she gets pregnant. See? And on doing their antenatal, we noticed that they have high blood sugars on doing their measurements. So gestational diabetes, we confirm gestational diabetes with impaired glucose tolerance or high blood sugars at 24 to 28 weeks of amenorrhea during pregnancy. So if a mother has high blood sugars at 2 weeks, it's not gestational diabetes. It was just undiagnosed diabetes, meaning the mother actually had diabetes before this pregnancy, and she has just carried it to this pregnancy. For us to say that the mother has the gestational, it is gestational diabetes, diabetes that happens during pregnancy, the time frame is between 24 to 28 weeks of gestation, not before that 24 weeks.
Does that mean that when a mother is pregnant and she has diabetes, she can transfer that to the newborn?
I'll answer it this way by talking about the science that usually happens. When the mother has diabetes, whether non-diabetic or it is gestational diabetes, it is still the same thing. The sugars are so high in the blood, and there is some bit of resistance still. So the concentration of glucose in the blood is a lot. Now, remember the mother is carrying a baby. Glucose has the ability to move through the placenta to the baby.
True.
So it moves freely. So because of that movement of glucose to the baby is going to consume some glucose. Because it is a lot reaching the baby will actually store most of it. Because it doesn't need it. It doesn't need a lot of it because it is a small baby. He will take in a bit to help him with the energy. But then majority of the glucose is going to be converted into fat and stored. So what is going to happen is that in the long run, we are going to have mothers, as the pregnancies progress, the babies are going to be big, babies 4 kgs and above, very big babies, because they are consumed a lot of glucose, so they end up putting on a lot of weight. So that is a dangerous thing for the mother, because the more the size of the baby, the more the challenges that the mother is going to have, because the child may actually have issues during delivery, obstructed labor because the baby is so big. They may end up having cesarean section because the baby is so big. And also to the baby, they may oftentimes have, because most of those babies, even after having a normal cesarean section, we actually admit them in the nursery, because too much glucose in the baby's blood is going to cause other hormones to come into play, stress hormones, cortisol and others, which will actually have an effect on surfactant. Surfactant is one of the, I would say in layman, a hormone that helps in lung expansion and growth. So oftentimes you notice that sometimes these babies actually have difficulty in breathing, or what we call asphyxia along that way, even if they have had cesarean sections. So they may end up having these complications that may warrant them going into the ICU. Mothers with gestational diabetes oftentimes don't transfer the diabetes to their babies. Yes, they don't, because it's not by diffusion. No, they don't.
Okay.
So the question would be, if my wife is having gestational diabetes, am I worried that my newborn is also going to be diabetic? No. Actually, what really happens is that because the baby has been in an environment where there is a surplus of glucose, when they get out and they come to, they get delivered, the environment where they are in now has no glucose at all. So what is going to happen is their sugars are going to drop to low. The sugars are going to drop drastically. So because we anticipate, even if they give birth to these babies, we check their sugars, and babies' sugars are maybe normal, or they are 5 or 6 or whatever, we still need to admit them and give them more glucose for some time, because they are moving from a high concentration of glucose to zero almost. See? And then you need to supplement them for a few. So notice that the worry would be, okay, mother has diabetes, I'm going to give birth to a baby who's diabetic, but now it's the reverse. Mother is diabetic, they say, okay, mother had gestational diabetes, is giving birth to this baby, and actually has low blood sugar. Yes, because of the science, as you have talked about it. So it is not correct that all mothers who have gestational diabetes will transfer the diabetes to their babies. However, remember, if there's a positive family of diabetes in the maternal side or the paternal side, chances are high that this baby will have diabetes in future. Not because of this gestational, but because of a family history and the genetic predisposition.
What are some myths about diabetes and hypertension that people have but are actually putting them at risk?
Some of the myths about this condition, the risk would be about the complications actually. Because if someone does not have the disease, you don't really care. Let me give you an example. If someone is not HIV positive, I use that for example, you will not really take caution to listen about the recent treatment guidelines, and because you're not having that problem. So the myth is actually in patients who have that problem, already diagnosed with diabetes, already diagnosed with hypertension, and they're actually seeking help. They are going all over the place looking for help. I'll tackle it this way. Majority of the patients, including us, I will not exclude us, because we are also human beings, we always want a lasting solution.
True.
All of us want a lasting, including doctors, we want a lasting solution. You want to know, okay, I've gone to Dr. Mtebi, and he has diagnosed with malaria. Treatment is 3 days, and I'm out.
True. This pill is 3 days.
I'm out. They have diagnosed with a bacterial infection, urine infection. A week at most, I'm out. I'm good. I'm back to my day-to-day activities. That is how usually we are wired as human beings. You want something that is going to take away your problem quickly and fast. And actually, that's where the herbalists nail it, because they know that they work on your psychology. They say, okay, Brian they told him that he has diabetes. Hey, what did the doctor tell you? The doctor told me I'm going to be on insulin. Insulin? You're finished. Me, I'm going to give you this jerry can, and whatever, in the hope that they will actually get well. They will get well, the diabetes will cure, the hypertension will cure. The reason why people pay millions in those facilities, I will not mention names. The reason why people pay millions in those facilities rather than to come to hospital and in the clinics for cheap drugs and insulin, which is actually cheap, is because there is some bit of assurance they get from there that actually their condition is going to cure and they are going to get over it. I'll emphasize. I will emphasize. Diabetes and hypertension do not cure. Even the patients talked about who undergo remission or who honeymoon, they are not cured. They are just honeymooning. It's like honeymoon. You don't go to Dubai in honeymoon for a month. Okay, a month you may. For a year, you cannot. That's not honeymoon. You go to wherever you go, then you come back to your residence where you stay.
True.
So it does not cure. However, we find a way of helping these people live with their condition and live normally. Your work relations don't go away, your relationship don't go away, the way you eat, the way we make sure that you regulate, that your lifestyle does not change drastically. Now, what are some of the myths that people have concerning these two conditions? The first myth that people have concerning diabetes and hypertension is that the first one I've talked about it, that diabetes can actually cure. I've already talked about it. Diabetes, hypertension, they don't cure. Number two is that when you take urine, I've had patients who come to me and they have taken urine, their own urine. They urinate in the night and then they take the urine in the morning. Or you may have heard of this, that some patients actually take animal urine. That one, I think some of you actually have heard about it. All those are not correct because urine is a waste, it is an excreta. So you're taking waste back into the system because the body already flushed it out. Even in animals, it's a waste. So there is no way it is going to have any impact whatsoever in your system when you put it back in. Third, the other myth that people have concerning these two conditions is that when someone starts on insulin, you're going to be on insulin for life. That myth is also not true. Being on insulin, it depends on the type of insulin, type of diabetes someone has. If someone has type 1 diabetes, they have lost all their beta cell reserve. Those are the people who are going to be on insulin, especially the young people. It is unfortunate that the insulin, they are going to be on it for life, but that it is what it is. But they have to cope up and they have to be educated. And we have quite a number of organizations that have also come up actually to help the young people, and we thank them for that. They're giving them free insulin, giving them free checkups, free glucometers, and actually they are doing very, very well as compared. Actually, type 1 diabetes is well managed, and the support is actually there. I will not say it's 100%, but at least there's a bit of support as compared to type 2 diabetes. So that's the other myth, that when someone starts on insulin, they are going to be on insulin for life. That is not true. It depends on the type of insulin someone has. Even if someone comes in with type 2 diabetes and I start you on insulin, along the way, depending on your beta cell reserve, I'll take you off insulin and then I'll give you other modalities and other agents to use, which may be oral. So it is not correct that when you're on insulin, you're going to be on insulin for life. Number two, the other myth is actually about insulin. For patients who are on insulin, most of them don't know about its storage. Most of them think insulin should be stored in a freezer, it should be put in water, put it in a lake, dump it in the sand, dig a hole and put it there. No. Insulin is very simple to store. If you have a fridge, just on that door of the fridge, just put it there. If you don't have a fridge, just get a small box, put in cotton, put in your insulin, put it bedside. Because it is a protein. It can be denatured by both extremes of temperature. It can be denatured by both extremes. It can be denatured. Denaturing means destroying. It can be destroyed by very cold temperatures. So you put it in a freezer to be destroyed. It can be destroyed by extreme temperature, very hot temperatures. So keep it in that small box, put in your cotton, it will be safe to use. Yes, so far, those are some of the myths that I've heard that people actually have concerning these two conditions.
Let me go back to the one of the urine, because that really stood out for me. So a patient will come to you and say, doctor, I have been drinking my urine for the past week or so, or month.
They usually don't go a month, because the side effects they get from that urine,
It's too harsh.
Yeah, they come within a few days. They take it for a few days and notice, I'm not doing well. So they come.
Wow.
So when they come, you try to correct or, talk to them. Of course, we don't judge patients.
Of course.
Because the reason why they are doing what they are doing is usually out of desperation. They are looking for a solution, which solution they think may actually lead to the healing of their condition. So we don't judge patients, but we have a discussion concerning the potential side effects from the actions they have taken, and then we see a way of helping them correct that and advise them on what to do.
For a parent who is at home, who has had this and wants to make sure they are prepared, or at least for the inevitable, what prevention can they have at home? Like how can they test their blood pressure at home, and what kind of remedies can they have in place to avoid, like a stroke or a heart attack in their family tomorrow? What can they do now?
The first thing, now we are talking about hypertension. For a family that has a patient who has hypertension or who is hypertensive, it may be one or two. Of course, now I talk about the adults. It's important that you have your blood pressure, a digital blood pressure machine at home. The importance of that is that it will help you monitor your blood pressure at home, what we call the home monitoring of blood pressure, which is actually the most accurate monitor of blood pressure. Because when you come to hospital or in the clinic and I'm putting on my coat, you will be,
you're stressed already.
I'm already. The doctor is going to, I have issues. So already stress comes in, your pressures rise. So some people actually just have white coat hypertension. They only get their pressures high while at the clinic. When at home, normal blood pressures. So we always recommend for clients to always have their monitoring of their blood pressure from home using the digital blood pressure machines. So what can be done at home to help combat or regulate? Number one, you have to monitor blood pressure. And how do you monitor blood pressure? You should be in a seated position, not lying down straight. Your legs should not be hanging. They should be touching the floor. Your hands relaxed on the thighs. And then they take your blood pressure. In case you take your blood pressure and you notice that the blood pressure is either extremely high or extremely low, have a second recording. It could be a miss, it could be a mistake by the machine. Have a second recording, have a third recording, and then you note that. Third, you need to, you have talked about the monitoring of blood pressure at home. The second thing is that you need to make sure that you limit or lower the salt intake. Don't stop, but regulate. Don't take, for the raw salt, that you have to take it out of your menu.
You cannot add.
Don't never add raw salt because it will harden your blood vessels and worsen your hypertension. However, the salt should be modest. The normal salt that we eat, that you eat it, you taste it, it's normal salt, not too strong, Yes. Then the third, regular exercise. Those ones I've talked about them. Regular exercise. And then the fourth, you need to make sure that you have at least once or twice a heart screen. You have an EKG or ECG done, because not only hypertension and diabetes can cause a stroke. Someone can get a stroke because there is a heart-related problem. The heart is fibrillating, it has a problem, and then it gets clots, and then they can get a stroke because of their heart. They are not hypertensive, they're not diabetic, but then they have a stroke. So you need to make sure that your heart is screened at least once or twice a year. You need to make sure that your cholesterol is checked at least twice a year. So you need to make sure that your cholesterol is always under check. So cholesterol, the heart, monitoring of blood pressure. If you're diabetic, monitoring of blood sugar, some of those things, and then regular exercise. For people who smoke, you need to stop, unfortunately, because smoking is a killer. It is a killer. I don't know why. Anyway, in Uganda, we have moved away from smoke. Majority of the population don't smoke. There are those few who do, but majority don't. But there is no benefit at all in smoking. Actually, smoking will increase the threshold of cardiovascular events and death by 50 times. So you need to make sure that you stop smoking. Alcohol intake, if you can stop, the better. If you cannot, you need to regulate. And the drink that I'm talking about here is about 12 ounces, if it is to do with beer. If it is wine, 5 ounces.
Wow.
That is the right way of taking for those who take some bit of alcohol. Because you wouldn't want to say, okay, take off already. No, you may take, but in more duration, in moderation.
What would you say are your top 3 pieces of advice that you can give someone today to help them avoid developing diabetes or hypertension?
The top 3 in order. Number 1.
I know number 1.
Which one?
Exercise.
Actually, exercise is not number 1.
Really?
The number 1 is cessation of smoking.
Okay.
That's number 1.
Okay.
Cessation of smoking. Because it escalates everything. Everything escalates because of smoking. So, number 1 is stopping smoking. Including e-cigarettes. People think, smoking is just this tobacco. Including chewing tobacco raw. Because people in the village chew tobacco. So, anything to do with tobacco, it could be smoking, e-cigarettes, it could be chewing, it could be sniffing, anything. Those have to be stopped with immediate effect. That's number 1. Number 2, exercise. Yes. Exercise. It will turn your life around. Number 3, you're waiting eagerly for the third one. But number 3 top thing to see that we prevent this is embracing checkups, because we are poor at health seeking as a nation.
True.
We, especially the men.
True.
The men. You know, even with HIV, you hear men saying, when my wife is okay, I'm also okay. You think you're okay, I'm also actually okay, but which may not be the case.
True.
So we need to have regular checkups. Don't forget, everybody is diabetic until proven otherwise. So let's get to the habit of going to the doctors. Let's get to the habit of having this at least once or twice. What are some things that we need to do at least once a year? Even if you're diabetic or you're not diabetic, you're meant to clock 35 years, actually 40, 35 to 40 years. Make sure that you have your eyes checked at least once a year. Go for a dental checkup. Go for a heart checkup, just a basic ECG. Go for let them check your RFTs for the kidneys. Have your urine checked. Let them check your liver. You need to have your feet checked. You need to have your vessels checked. Not checked in a sense of imaging a word, but the doctor checking all those things. And then your cholesterol. So at least once a year, those should be actually done. If someone has diabetes and there is a family history, you need to take it a step further. On top of those things that you're doing, that I've talked about, make sure that your thyroid is also checked, because type 1 diabetes actually is an autoimmune disease that may call for other autoimmune diseases like thyroid disease and others, among others. So you need to have your thyroid checked, eyes checked, a dental formula checked, the heart checked, the kidneys checked, the cholesterol checked, the liver checked. Once a year. The question is, how much does it cost? Depends where you go. However, averagely, for an eye checkup, you only need at most 20,000. You go, and they do a checkup because your vision is okay anyway. You've just gone for a checkup. You have not gone to pick glasses. A dental evaluation, still, you just pay consultation, the doctor check you. In case they find a problem, it's not urgent. You can always prepare and go back for that problem to be fixed. But oftentimes, we wait until we have the holes in our teeth, then we can go and see a dentist. In fact, patients who are diabetic should actually have their dental checkups done once a year, because the more, if someone gets infections of the gums or the teeth, what we call periodontitis, and actually worsen blood sugar. So you see that sugar is not controlled, you've done everything, you've optimized care, and sugar is not dropping. The problem could be the teeth. So we advise at least to have a dental checkup once or twice a year, eye checkup at least once a year, heart checkup, ECG or EKG at least once a year. Have your RFTs or LFTs done at least once a year. In case there's an issue with any of those, they can actually be done routinely, maybe every after 6 months or 4 months. Then for the liver, don't forget, or we always forget to do a scan. Yeah, the reason for the scan is that most patients with diabetes actually have fatty liver disease. So we always want to do a scan, have a look at your liver, we see if you're not accumulating a lot of fat in the liver. Not to forget, if you go to the doctor and the doctor doesn't touch your feet, you see, I'll give a myth. I'll give this statement. I'll make it that the highest form of honor is touching people's feet. That is the highest form of honor. For those who are Christian, you know very well that Jesus actually washed the disciples' what? Feet. Yeah, he washed them. So what I'm trying to say is that I'm using it as analogy. So the point I'm trying to put across is that when you're diabetic and you're on treatment and your physician forgets to check your feet, remind them, hey doctor, you have not checked my feet, because they may catch a problem there early and it can be solved quickly. Because I've said, diabetes actually causes nerve problems, but also vascular problems with the feet that can actually lead later into cutting off of the limbs. So the moment we notice that there is a problem early, we sort it out. And this should be done per visit. It should be done per visit. So sometimes we are busy and we have heavy clinics. You know, if you're in a good relationship with your physician, you just tell him, doctor, can you just have a check on my feet? Yeah, and then he can advise you on what to do in case there are issues there. So the 3 things are those. Number 1, cessation of smoking. Number 2, exercise. And then number 3,
regular checkup.
Annual or basically checkups. And then the last is the bonus is controlling weight. Very, very important. You need to make sure that your BMI comes down. Yeah, if you have BMI of 30 and above, make sure that it drops. Pull it down. Do those exercises. Change your eating habits. All those things are done to see that we combat obesity. No good thing comes out of obesity. We used to say that, that one has a big stomach, is rich. No, actually, the more you have a big stomach, the worse for you, because it is going to predispose you to all forms of these non-communicable diseases that you've talked about. So it is important that you control weight. For people who have a BMI of above 35 kilograms per meter squared, those actually, the recommendations actually recommend bariatric surgery. The moment you have a BMI of 35, regardless of whether you have any comorbidities, regardless of whether you're diabetic, regardless of whether you're hypertensive, whether you have kidney disease, 35 and above, bariatric surgery. However, it is still something that is just coming up in our country, and it's very expensive. So people rarely go for it.
Is there any hope for patients who have diabetes or hypertension? Based on what we have seen or what we have, discussed, it seems gloomy, apart from exercise and all these other things. But is there any new, I would say, inventions or medicines or research that you're seeing that can give hope to people who are affected by diabetes and hypertension in managing those situations?
In terms of medication, I will tell you right now that at least we have some molecules on the market called GLP-1 agonists.
What is molecules?
Molecules are drugs.
Like tablets?
They're actually injectables.
Okay.
They help in managing diabetes. They also help in weight loss. So we use them in patients who have both. Someone is obese, or morbidly obese, but they are also diabetic. So we use them. We have them on the market and they are very good. And we use them just once a weekly injection and you're sorted. So we can actually employ some of those, but they are also very expensive because an injection of a GLP-1 agonist like liraglutide, semaglutide can actually go for about 1.8 to 1.6.
Wow.
And that injection actually takes you for only 4 weeks because you get one injection per week. For those who can afford, it is something which is good to go for because they have the advantages. They help lower your blood sugar. They help control or reduce weight. They have cardioprotective effects. They protect your heart, renal protective, but they are there on the market. Just to emphasize on the point of screening for diabetes, is extremely important to screen for these conditions, diabetes and hypertension, because as we have seen, the prevalence and the incidence of these two conditions are very high, even globally. So we need to screen. For hypertensive patients, make sure you do your home monitoring of blood pressure. On hypertension, I would say one of the leading causes of strokes, on top of what we have talked about, is patients who actually don't dip in the night, the non-dippers. Non-dipping means when you sleep in the night, your pressures just skyrocket. Ideally, when you rest, everything rests, including your blood pressure. It should be at its lowest. So you notice that some people actually don't dip in the night. So the non-dippers are the major causes. That non-dipping is one of the leading causes of strokes. And then number two, patients who are hypertensive, they need to monitor their blood pressure in the morning, when they come back at work, but also late in the night to catch those non-dippers. When you sort that out and their pressures are okay, the chances of having strokes exponentially decrease, among others. The other is, of course, self-monitoring of blood glucose. You need to monitor. I didn't talk about that extensively. You need to monitor blood sugars while at home. You need to have a glucometer personally. Every before a meal, check your sugars. Every before you take your medication, check your sugars. And make sure that in case you have the episodes of hypoglycemic awareness, episodes of hypoglycemia, low blood sugars, come to your clinician or your physician and have a discussion. Don't forget to have a logbook to monitor your pressures.
And write what you measured.
Don't leave them in the phone, don't leave them. Have a book. Take your measurement for blood pressure, record the date and the time. Take a measurement for blood sugar, record the date and the time. And then that log will guide your physician on what to do next. And lastly, as I conclude, let's all as Ugandans be active in terms of seeking health. Let's improve on our health-seeking behavior. Coming to hospital once a year, even if you don't have any pain, it will cost you less than having a complication that you have to treat very expensively. So you can decide that at least every beginning of the year or at the year is ending, collect some money. At most, it should take you 200,000 Ugandan shillings to have all these things done in a center that is in a big center in Kampala. So in a government hospital, in a government facility, the prices actually are much less, almost equal, less, half of that or less. So let's improve on our health-seeking behavior. Let's always be on the lookout. Anything that you see that is not usually the normal, always seek help from the doctors and the physicians.
Thank you so much for coming on the show. We want to wish you success in your work. Keep treating and healing people. And if there are new developments in the field, please come back and let us know on the show.
Thank you so much.